Awesome. Thank you so much for the introduction and welcome to everybody who's decided to come learn about some Cushing's on a nice Wednesday evening. I'm happy to be here and happy y'all decided to come learn a little bit with me. We're going to start today just kind of talking about what we know and kind of where we're coming from and then kind of what the path forward looks like for Cushingoid management. And so I think it's easy to kind of know a couple of big concepts. So we know that treating hypercortisolism definitely improves survival compared to leaving these patients untreated. While the numbers don't look great in some of these older studies, 2-year survival rate's about 50%, whereas is untreated is 8.5%. So we know that there's definitely a survival benefit through going through the process of reducing the cortisol concentration in these patients. What's interesting about this is that Cushing's is very rarely a cause of death for patients. However, the owner perceived quality of life, while treated, tends to be better than untreated. Even in treated patients, the quality of life tends to be reported as not great by clients. What are we doing wrong that is misshaping this perception of kind of how these animals are responding to our interventions? And I think a lot of this is going to have to do with the presence of comorbidities, and we'll talk a lot about this today, but we know that comorbidities are present in at least about 2/3 of patient, if not more. And of those patients that have comorbidities, at least 1 in 5 of those have at least two or more comorbidities going on in addition to the hypercortisolism. And so a lot of the quality of life and kind of just in general how the patient is doing may be a factor of some of these comorbidities that oftentimes may be associated with Cushing's, but may not always be recognized or treated appropriately along the path. We'll talk about some of these today. Kind of the ones that are highlighted tend to be the ones that people overlook the most. And so I think we'll talk a little bit about hypertension and proteinuria today. While we know that there's some well-established breed associations with gallbladder mucocele formation, like in Shelties, gallbladder sludge and gallbladder disease is very common in this patient population. And so that is also something that we need to keep on our radars. I'm sure we've all have seen some of these other comorbidities that are associated with this, in particular things like hypercoagulability or ligamentous injury and larger breed dogs, delayed wound healing or increased predisposition to infection, and then some of these neuromuscular syndromes that will pop up from time to time. And so we've gotten better at acknowledging that these can be associated with it. And I think where we find a lapse is that treating Cushing's doesn't always resolve some of these comorbidities, and therefore we do need some extra interventions in a set population of patients. I think things that we've done really well are we are so much better at earlier detection of clinical signs and having a jumping to this being on a differential list a lot faster than what used to occur. We are very good at screening patients and diagnosing this disease early, and we are very good at instituting appropriate therapy for these patients. And as a result of all of that, gone are the days where a lot of these patients present with really severe complications of Cushing syndrome. And so things like pulmonary thromboembolism or organ infarctions. This is a picture of a dog that has myotonia or kind of a muscle rigidity syndrome that oftentimes will first manifest in the back legs of these patients. The top picture is a dog that has really severe calcinosis cutis and these plaque-like rock lesions kind of all over its body. And so these aren't typically the patients we see anymore. I would say this is oftentimes kind of the patient that we're seeing now that ends up getting diagnosed with Cushing's because the owners are picking up on clinical signs a lot earlier, and then we're screening biochemically and being able to test these guys. And so I think there is a big improvement in our detection rate, and therefore, luckily, a lot of these bad things that happen to these patients are no longer things that we deal with commonly. So this is kind of the outline of things I wanted to discuss today with y'all. And so diagnostic testing, we know is imperfect and often frustrating. And interestingly, we just had our big endocrine society meeting last week, and there's been some new developments and conversations that have happened that may impact kind of how we work up these patients or kind of the tests we use to diagnose them. And then we'll talk about treatment and some of the frustrations with that, as well as some of the updates and monitoring and different protocols that people may be using to monitor therapy in these patients. And so kind of throughout the talk, we're going to kind of use Arthur as our example, mainly because he's my favorite patient of all times. He is a 10-year-old male-neutered basset at the time that we first saw him. He presented for PUPD and excess panting, and I think that's always one of those clinical signs that people laugh about, but like it's a really important clinical sign for Cushing syndrome, and it's not something that we should dismiss because sometimes that may be the only pathologic sign that these animals are presenting for, and it's like to the point where it's keeping these owners up at night because the animal's panting excessively. And that was a really big component to Arthur's presentation. On his physical exam, he did have alopecia and pot-bellied appearance, but he's also a basset. And so we were like, how do we interpret that? Luckily, on biochemistry testing, we did have a lot of consistent biochemical findings. So things like thrombocytosis, cholestatic hepatopathy. On urinalysis, he did have proteinuria, and whenever we ran his UPC, it was near glomerular level proteinuria. Blood pressure was elevated at 170, and then on ultrasound, we did have, again, confirmation that his liver fit with cortisol excess patient. He had biliary sludge noted, and then bilateral adrenomegaly with a couple of nodules noted in his adrenal glands as well. And so kind of working up these patients, I think one of the things that we need to be really careful about is not willy-nilly screening patients for Cushing syndrome. I think we really maximize the accuracy of these tests that we have access to by selecting the appropriate patient population to actually screen for this disease process. And so, kind of as a general rule of thumb, keep in mind that these are imperfect tests, and all the tests we're going to talk about are very prone to giving you false positive test results. And unfortunately, the medications we use to treat Cushing syndrome are not great medications to put healthy animals on. And so we really want to make sure before we commit an animal to trilostane or mitotane therapy that we feel confident in the diagnosis of their disease. And so in general, we don't recommend testing sick or stressed patients. The one situation where you may not be able to avoid that is if they're sick or ill because of a sequela of their hypercortisolism. And so sometimes we do have to try to interpret through that external stress factor. So kind of as a general rule of thumb, I say, really, we should only be testing if your clinical suspicion is high for Cushing's. And usually that's going to imply that there's at least two clinical or biochemical changes that fit with the disease process before you would start reaching for Cushing's tests. The one exception to that would be if you diagnose a patient who is not on exogenous glucocorticoids with calcinosis cutis. That is relatively pathognomonic for this disease process. And so at that point, it would be appropriate to go ahead and screen that patient for the disease. And so again, proper patient selection is very important. We'll talk about some of the things that we could also do wrong along the way, but this is one thing that we can very easily do. And so I kind of like to think about testing options in a couple of ways. So we historically have had a screening test, the urine cortisol to creatinine ratio. And this is something that we've historically used to rule out the disease. And so we've always said that this is probably the most sensitive test for Cushing syndrome. And so the reason why that's important is because if you have a 100% sensitive test, that means you have 0% false negative results. And so you can believe a negative result, which is why we use that to rule out the disease. We'll talk about some issues with the UCCR here in a second. Diagnostically, we're running the low-dose DEX or the ACTH stimulation test to rule in the disease process in animals that we have a high clinical suspicion of. And so kind of the classic example we used to use the UCCR would be an animal that has no clinical signs, that has a progressive alk phos elevation, and you really just want to rule out Cushing syndrome, or the client has Dr. Googled stuff and you just want to be able to say, hey, it's not Cushing's, even though you think so based on your Dr. Googling, this would be a good test to run. However, there's been some limitations on this test here in the past couple of years. And so this is a paper that just came out. Francesca DeBaldo is a veterinary endocrinologist in Italy. She's about to become the president of the European Endocrine Society. This was a really good test or a paper that they published. And so this assay for cortisol that they were using is the Emulite 2000, which is probably one of the most common machines that most reference laboratories or academic institutions are using for endocrine testing. And so it's an immunoassay, chemiluminescent assay. Historically, the Emulite 1000 kind of used a certain antibody in the cortisol assay testing. However, with the Emulite 2000, they have updated the antibody that was used. And while we all thought that it was going to be relatively similar performance as the old antibody, it looks like it's not performing the same way as the previous antibody. And so, interestingly, in their study, whenever they looked at urine cortisol to creatinine ratios in these dogs, the sensitivity of the UCCR in these patients was about 80%, which is honestly no better than an ACTH stem or a low-dose dex test. And so I think now, depending on the methodology that's being used by the lab you're sending your cortisol testing to, we got to be really cautious with overinterpreting a negative urine cortisol to creatinine ratio because you could be missing 1 in 5 Cushingoid patients by using this test. And so I would say I currently don't recommend using this as screening for Cushing syndrome. I don't allow my residents to use this as screening for Cushing syndrome. However, if you are using an lab that has different methodology that's not using the Immulite, it may still be okay to use. But just be aware that this is an issue, and so it is worth checking in with your lab before submitting for this. The UCCR is still good for Addison's testing. That's another talk. But for Cushing's, most endocrinologists at our meeting are no longer using this test for screening purposes. And so whenever we look at what cortisol assays are available, there is a liquid chromatography and mass spectrometry assay. However, that's not widely available and a lot of the times is not what most labs are going to use. Historically, and currently, we mostly are using immunoassays. And so the radioimmunoassay or the RIA is an old test that was very good and very reliable. However, it does involve some radioactive material, and so it's no longer widely used by most labs because of the radioactive handling and kind of the time it took to perform this test. Most labs are currently using chemiluminescent assays, and so most reference labs that you're sending this to might be using the Immulite 2000. I think something else that we've discussed extensively at this endocrine meeting was now that we have this new antibody that doesn't appear to be the same as performance-wise as the previous antibody or some of the original studies that used RIA to set some of these reference ranges is we may now need to go back and look at and reestablish what reference ranges look like for all of the Cushingoid tests to make sure that if we're using a machine like the Immulite 2000 that we're actually getting accurate results. And so there's probably going to be a lot of information that comes out about this over the next year or two. I think one of the nice things, and obviously while we're all here today, is to talk about the Truforma, which is Zomedica's benchtop kind of point of care endocrine testing machine. And we have this at Texas A&M. We've used it at the University of Georgia whenever I was there. And we really like it. And so it is a nice addition to our clinical pathology lab that allows us to have rapid result reporting and to be able to overcome some of these issues that we have encountered with some of the other assays that are more commonly used. So kind of looking at some of the tests that we would use. And so low-dose dex is probably what, if you ask most endocrinologists, is what we would prefer to run if we could in all of our Cushingoid patients. It is reported as a very highly sensitive test. And so again, it's less likely to give you false negative test results. And so if it's negative, you're more likely to believe the result and that the patient's not Cushingoid. The problem with the low-dose dex is that it is very sensitive and very prone to therefore giving you a false positive test result. And so it can be highly impacted by the stress of the patient, by the presence of uncontrolled comorbid diseases, or by us not housing the patient or handling the patient appropriately during the low-dose dex test. And so there's been a lot of studies that looked at ways to avoid iatrogenic false positive test results with this. And so I think one of the biggest things that we could do is if you know the animal has a comorbidity, try to regulate that comorbidity as much as possible. It doesn't mean it has to be perfectly controlled, but try to get it as regulated as possible before performing a low-dose dex. It helps if you can acclimatize the pet to the environment that the test is going to be done in. This is one of the reasons why we don't do a lot of low-dose dexes in an academic setting, is because we are not the ideal environment for this. The client is driving a 2-hour drive to come see us, and their full day appointment is a new environment to them that they've never been in. And so this is a big deal for us. I think at a local practice, if it's a dog that's been seeing you for 10 years, they may be relatively acclimatized to your hospital environment. And so it may not be as big of an issue with them. And so Oftentimes, if I'm doing a low dose dex at Texas A&M, we're hospitalizing the patient at least overnight, if not 2 nights, and allowing them to acclimate to the environment, and then performing the test the next day to kind of mitigate some of the initial stress from the day one presentation. I usually tell vets whenever they consult with me, if you have a boarding facility in your practice, kind of the last run in the dark corner of your boarding facility is kind of the ideal place to house these patients during a low-dose dex. I think unfortunately what happens is a lot of these patients get housed in the cages in your treatment room while you're doing a dental on a dog and you're text vaccinating a fractious cat. And therefore, it's not a great environment because that is going to be stressful for the animal and then therefore could risk the accuracy of your cortisol results. The other thing that's interesting is that you literally don't want to do anything else with the patient during a low-dose dex. And so it's been shown that vaccinating patients during a low-dose dex, ultrasounding them to get a cystocentesis during a low-dose dex was enough of a stressor to cause false positive test results. So anything you need to do with the animal, get it done at a prior or following visit from your low-dose dex. But during the low-dose dex, you only want to handle them when it's time to give the medication or get your samples for cortisol testing, but try to avoid the tendency to do anything else with these patients during that time. Procedure for low-dose dex. Most of us are using 0.01 mg per kg dexamethasone given IV. As a reminder, if you're using Dex SP for this medication or for this test, the concentration of dexamethasone in Dex SP is 3 mg per mil, and so we usually use that as we're calculating what our dose of dexamethasone will be. And outside of the US, they have other products like Dex SP that's 5 mg per mil, which has a 4 mg per mil concentration of Dex SP. So you just may want to check what formulation you're using and use the appropriate dexamethasone concentration. There's also DACVIM that's out there that a lot of people like because it's less concentrated, and so it's 2 mg per mil. That may also be helpful for smaller breed dogs that may allow you to more easily pull up the dose for their low-dose dex. Sample-wise, we need a pre-dex injection cortisol sample and then a 4 to 8 hour post-injection cortisol sample. While we're getting 3 samples, I think it's important to recognize the diagnostic sample that we're going to look at to say yes or no to Cushing's is the 8 hour cortisol sample. And I think this is where a lot of confusion comes into play with interpretation of this test is because people start looking at the 0 and 4 hour concentration and kind of confuse themselves about what to do. And so I usually recommend a standard process for interpreting a low-dose dex test. And so answer these 2 questions in the same order every time, and hopefully it will help reduce some of the confusion that comes along with this test. So the first question we have is, does this animal have hypercortisolism? And that's why we look at our 8 hour concentration first. And so if your 8 hour cortisol concentration is greater than equal to 1.4 micrograms per deciliter, it is most likely consistent with that animal having Cushing syndrome. Again, assuming that they've had appropriate patient selection and appropriate test performance. If the 8 hour is less than 1.4, it's very unlikely the animal has hypercortisolism, and we're done with the test. We don't need to look at anything else. You're good. Doesn't matter what 0 and 4 hour are, put it away. We're done. There is this inverse pattern that is a common reason for people to get confused, where the 4 hour concentration has not suppressed yet, but the 8 hour concentration is suppressed. This can be suspicious for kind of a delayed suppression of the cortisol concentrations. However, it is not diagnostic for hypercortisolism. And so I think if you have a patient that you have a high clinical suspicion of disease, you may consider running an ACTH stim or repeating the low-dose dex after a couple of weeks or a month, depending on kind of how stable the patient is. But I would be hesitant to jump to putting a patient on this, especially if they don't have really severe clinical signs of hypercortisolism. If you've answered yes to number 1, so the animal does have Cushing's, then the question to number 2 is, can I use this test as a differentiation test to diagnose pituitary dependent disease? And so this is where our suppression criteria come into play. And if you notice any one of the 3 suppression criteria, we can say then yes, this animal most likely has pituitary dependent disease. And so these are our 3 suppression criteria that we use. By far the most common occurrence, as well as the most frequent suppression criteria that occurs, is the 4 hour cortisol concentration is less than 1.4. And so we use this a lot. About 75% of patients are going to have this criteria met on their low-dose dex if they have PDH. The 4 and 8 hour concentration less than 50% of baseline make up the other 25%, kind of split between those two. I think the one thing to keep in mind is lack of suppression does not mean the animal has adrenal dependent disease. Up to 40% of PDH cases will not suppress. And so we get about 5 to 10 referrals per year for an adrenalectomy because the vet did a low dose dex that didn't suppress and they referred it for surgery. So keep in mind if you're playing the odds, 85% of cases are going to be pituitary dependent in origin. And so even if you don't see suppression, chances are it's still likely to be pituitary dependent disease. So do not diagnose adrenal dependent disease based on a low dose dex alone. So Ken, here's an example I gave for y'all. So a baseline of 6, total, or excuse me, T4, time 4, 2, and a time 8 of 3.2. So I usually tell my students is the first thing you do is just cut the baseline in half and then kind of plug it into these equations above. And so the baseline is 6, half a baseline is 3. So 3 is not less than 1.4. However, it is less than 50% baseline at 8 hours. And so therefore we've met one of the 3 criteria. And so we can say this animal most likely has pituitary dependent disease. And so it can be nice, and this is why a lot of us like this test, is because it's both diagnostic and has the potential to be a differentiating exam as well. This is Arthur's test, and so again, he started out at 5.6 and then was 4.2 at 4 hours and 3.8 at 8 hours. And so we didn't see suppression in him. But again, that all we can interpret from this test is that he has Cushing's, and therefore we cannot tell what type he has. The ACTH stimulation test, oftentimes whenever people talk about it, they give it a really bad rap. And oftentimes they'll refer to it as a moderately sensitive test. I think that this is a lot of the times overstated. And if we think about most cases of Cushing's that you're going to see in your practice being pituitary dependent disease, the sensitivity is relatively comparable to the low dose dex. And so where the ACTH stimulation test falls short is in adrenal dependent cases, and that you basically have a 50-50 shot of getting a positive test for adrenal dependent cases. A lot of the times they're going to stimulate into the gray zone that we'll talk about here in a second, but may not be robustly positive to allow you to feel comfortable with the diagnosis. The one nice thing about the ACTH stimulation test, and the reason why you may see the specialist that you refer to running this test more often, is that it tends to be more specific than the low dose dex in the presence of stress or concurrent illness. And so a lot of the times, because of the trip to the teaching hospital or the new environment or the presence of 5 comorbidities in the patient, that we rely more heavily on the ACTH stimulation test in our patient population. But I think your run-of-the-mill cushingoid dog that comes into your practice most of the time is probably a good candidate for a low dose dex. And so we try to tell the students to not get a false sense that the ACTH stim is what we would prefer, because in practice, most likely they should be using the low dose dex. For our protocol for ACTH stimulation testing, we usually are going to use synthetic ACTH or concentropin. The dose that we use is 5 micrograms per kilogram for diagnostic purposes, and we give this IV ideally. If you have a very large breed dog that calculates above 250 micrograms, the maximum dose that we would give is 250 micrograms, or the full 1 ml vial of concentropin. We'll talk about this in a little bit, but we can aliquot the concentropin vial out into smaller doses for smaller animals to be able to provide some cost savings associated with this test, since concentropin tends to be one of the more expensive aspects of doing an ACTH stim. For IV testing, we're going to get a baseline sample and then a 1-hour post-stimulated cortisol concentration. There are compounded concentropin gels that you can use for this. And if you're using the gel, because there can be variable absorption, they usually recommend a 0, 1, and 2-hour post-stimulated cortisol concentration. But for most IV, and honestly for most IM injections, a lot of the animals are going to peak their cortisol at about 1 hour. So the 2-hour concentration with IM is just to kind of catch some of those slow responders that may have a delayed peak. But again, most of the time, if you only had to pick one time point, it would be 1 hour post-stimulation. Interpretation is a lot more straightforward for the ACTH stim, and so we have a relatively wide normal zone. A lot of times the reference labs are going to report a baseline concentration and have a reference range for that. Again, there's no real normal baseline for cortisol. So if you have a low-key, non-stress lab, they're probably going to have a lower cortisol. If you have a high-stress Chihuahua, they might have a higher normal baseline cortisol. And so don't freak out if you have baseline cortisols that appear to be outside a reference range. The gray zone is where most people kind of end up hating this test, is because you get this inconclusive result and can't definitively say you're comfortable with that being confirmatory for Cushing's. Interestingly, a lot of labs may use anywhere between 20 to 24 to suggest Cushing syndrome. And so I'd say check with your lab and kind of see what their recommendations are. However, I would feel comfortable if I had a high clinical suspicion of the disease and my animal stimulated greater than 20, that I would say that that most likely fits with Cushing syndrome in that patient. Couple of things to remember. This is not a differentiation test. And so if it's positive, it only tells you they have Cushing's and doesn't tell you which type of Cushing's they have. And for me, if I have a high clinical suspicion of the disease and I test a patient and they stim to the gray zone, and then a month later I test them and they stim to the gray zone, that's probably enough for me to feel comfortable going ahead and instituting treatment. And so if you have multiple gray zone results in a highly clinical patient, one, if you haven't done an ultrasound, I might do an ultrasound to make sure they don't have an adrenal tumor. But two, I would go ahead and do a treatment trial and institute therapy, because most likely that's not normal for an animal to stimulate that high multiple times. Differentiation testing is probably something you got drilled into you in school, and it's something that we talk about a lot. However, it's not really an essential aspect of the patient's management unless the animal would, or the client would, consider doing an adrenalectomy or a hypophysectomy for definitive treatment of the underlying Cushing syndrome. And so if they're not going to do that, most of the time we're going to treat it the same way regardless of what form it is. And so it may not be worth going through the exercise of differentiating the type of Cushing's. But if we're going to, these are the tests that are most commonly used or available. I highlighted the ones that are most commonly utilized in a practice setting. Obviously, again, if you've done your low-dose dex and it's differentiating, great. Historically, people have relied on the high-dose dex if they didn't suppress on the low-dose dex. It's the same test. You just move your decimal place over 1 for your steroid dosing. So instead of 0.01, it's going to be 0.1 for dogs or 1 for cats. And the same suppression criteria apply, and you're just hoping that with the higher dose of dex, that you're able to induce one of those suppressive criteria to manifest that didn't during the low dose dex. The downside of this is it's another 8-hour test, and so it's another day in the hospital that we're having to do this test. And there's a relatively similar amount of animals that aren't going to suppress even with pituitary dependent disease. And so it's kind of fallen out of favor a lot more so now that ultrasounds become more readily available to almost every practice in the country. So abdominal ultrasound or adrenal ultrasound is what most people are currently using as differentiation testing to kind of see if they have bilaterally normal or enlarged adrenal glands versus an adrenal nodule or a mass. I highlighted endogenous ACTH because historically this was something that was only really able to be done in a specialty setting, because endogenous ACTH is a really labile hormone. And so if you don't handle the sample appropriately or ship it to the lab appropriately, you're most likely going to get false results reported. And so your accuracy is not going to be great. And the reason why I bring this up is because one of the tests that the TRUFORMA does perform is an endogenous ACTH concentration. And so this has really, for us, even in an academic setting, allowed us to use this as a differentiation test a lot more commonly for these patients. And so as this machine is out there and kind of gets utilized more, this may actually be an option for patients that may not be able to afford an ultrasound, that may not have suppressed on a low-dose dex. So just be aware that it is a good test, it's out there, and we like it. The reason why I like it as a follow-up is, remember that ACTH is a breakdown byproduct of a larger substance called POMC. And so ACTH is this little highlighted in the box, 1 through 39 substance. All of these other things that are made from the breakdown of ACTH are not ACTH. And so I don't necessarily need to measure all of those. And so we kind of call all of this kind of the pituitary soup. And a lot of the assays that are out there measure all of these things within that pituitary soup, which is not really specific for endogenous ACTH. This is a really big deal in large animal, because for horses with Cushing syndrome, Cross reaction with things like alpha MSH can give you inaccurate results or cause false interpretation and may impact your decision making. And so the ideal test for endogenous ACTH would be able to specifically look at ACTH and not pick up on the rest of the pituitary soup. And so one of the nice things about the endogenous ACTH cartridge for Forma is that the amount of cross-reactivity with a lot of that pituitary soup is minimal to non-existent. And so whenever you get your result, it truly is a reflection of what the animal's endogenous ACTH concentration is. And so that's why one of the reasons why we like this test and feel like we can interpret it well in our patient population. And so we use this probably at least several times a week. So other challenges to discuss once we get the diagnosis and or differentiation. We know that we have effective treatment options, both medical and surgical, but still, even with treatment, the owner perception of quality of life is poor. And so we'll talk about some of the comorbidities and some of the frustrations that can be encountered during the initial phases of treatment. So again, kind of looking at Arthur's case, a couple of things worth pointing out would be, again, he did have a UPC elevation, which is common with cushingoid patients, as well as hypertension, and then his biliary sludge. And so kind of the questions that we get a lot of the times are, do I need to worry about these now, or do I just need to treat the Cushing's and come back and look at these in the future? And I would say most of the time it's fine if you have just diagnosed Cushing's, if they're not severe and not causing their own problems, to let the Cushing's get treated and kind of see if these resolve or remain as residual problems. And so kind of things to consider with some of the comorbidities would be things to treat now at the time of diagnosis of Cushing's, if they're present, would be hypertension in the presence of end organ injury. And so if you have dilated retinal vessels or retinal hemorrhage or an acute renal injury and creatinine elevation or neurologic signs, and yes, don't wait on treating the Cushing's, start them on amlodipine, drop the blood pressure and get that under control, keeping in mind that as we treat the Cushing's, we may need to adjust the doses or discontinue some of these medications. Hypercoagulability, if it's present, a lot of the times we may backdoor our way into this by doing an abdominal ultrasound to screen for other disease processes, and incidentally we find a splenic vein thrombosis or infarcts in organs, or animals that have really severe thrombocytoses as a result of the Cushing syndrome. And sure, it's unlikely that clopidogrel is going to hurt, and it may help prevent them from developing thromboembolic disease. About 10% of Cushingoid animals are diabetic at the time of diagnosis. And so even if it's caused by the Cushing's, the animal's diabetic. And so you have to treat the diabetes. And so these animals need insulin, even if they're going to be one of these rare animals that goes into remission after you treat the Cushing's, they still need insulin until we control the Cushing's. So we're not going to be flipping a switch and gaining control of the cortisol levels overnight. And so put them on insulin, put them on a diet. Most of the time, Cushing's is not the cause of diabetes, it's the cause that pushes the animal's pancreas over the threshold to no longer be able to support appropriate insulin production. And so these animals oftentimes are going to be permanently diabetic even after control of the Cushing syndrome. So treat diabetes if you diagnose it. And then gallbladder disease, if it's a gallbladder mucocele or inspissated bile or the sludge is starting to kind of take on form, then we would usually recommend ursodiol therapy as a way to try to increase the liquidity of that solution and kind of get it into the small intestine and prevent it from developing into a mature mucocele. But I think the big thing to remember is a lot of these comorbidities are going to improve, if not resolve, once we control the cortisol concentration. And so again, if we're starting amlodipine or if we're starting insulin, that we need to kind of keep in mind that we should be monitoring these parameters closely to make sure that we don't need to dose adjust or discontinue as we start getting control of the Cushing syndrome. So Arthur's UPC, again, remember, was 1.9 and 170. He did not have any evidence of end organ injury. While having a UPC of 1.9 is not great, it's probably not going to kill him over the next month. And so I probably have time to treat the Cushing syndrome and then reevaluate what his level of proteinuria is before deciding to go down the proteinuria treatment route. I think this is where a lot of the times we run into issues, is that we find these things at diagnosis and then we forget about them because we get hyper focused on the Cushing's and kind of controlling the Cushing's disease. And so if you've diagnosed these things, make a note in the record to follow up on them after the cortisol is controlled, because if there is persistent hypertension, persistent proteinuria, then we do need to enact specific therapies for those abnormalities. Again, hyperlipidemia, high cholesterol, high triglycerides, and or surgery to address some of the other things we talked about, like cranial cruciate ligament disease, or if they do have mature neutrophils or calcium, mucoceles, or calcium oxalate urolithiasis. The one thing that is unlikely to improve if noted at diagnosis is going to be this muscle rigidity syndrome. And so I usually prep owners for, if they have a rigid gait or they have, abnormal ambulation, hopefully they're not as bad as this dog in the picture, but that's the least likely comorbidity that is going to resolve with cortisol controls. Those changes may be permanent in that patient, even though you did your job great and treated the patient appropriately. And so again, expectation setting is important for these guys, just so we don't get their hopes up and the animal may go back to being completely normal. So what about treatment? We do have an FDA-approved effective therapy. And so trilostane or Betaril, the brand name. Again, the label dose is a higher dose labeled for once a day. Yeah, I put just a small selection of papers that have shown that it is much better as a twice a day therapy. And so we should be recommending this as a twice a day therapy starting at a lower dose. And so most of us are usually calculating the dose around 1 mg per kg. Because of capsule sizes, you have some flexibility as far as going anywhere between less than 1 to up to 3 as a starting dose twice a day. And so again, I calculated on 1, and now they've added so many capsule sizes that usually it's easy enough to find one that works, that it stays relatively close to that 1 mg per kg twice a day. The last couple of references on here, we're specifically looking at compounding of trilostane. And unfortunately, it's not one of the medications that's very amenable to compounding. And so if you look at different compounding pharmacies, there's different uh, concentrations or efficacy of these medications between pharmacies, in addition to within the same pharmacy. And so one batch may be really effective and the next batch may be less effective. And so in general, what I warn people about with compounded trilostane is that kind of the level of control for the patient is more likely to be waxing and waning over time. So the client may be appreciating intermittent clinical signs of not well-controlled Cushing's on compounded formulations. And so as much as possible, it's ideal to avoid compounding. Sometimes if you have teeny tiny animals, it's impossible to not compound. Or for cost-related reasons, sometimes it may be worth having waxing and waning control and tolerating some minimal clinical signs to save some cost on the medication. But I definitely think there's enough evidence out there now to suggest this is one of those medications we should try to use the brand name product as much as possible. If you are using compounded and you're having a hard time controlling the animal's disease, switch back to the brand name because most likely it's going to be an impact of the compounding process. I think other things we should still discuss with clients are if you've been diagnosed with pituitary dependent disease, hypophysectomy is a proven definitive therapy for pituitary dependent disease. In the United States, there's only a few places that are doing it. Texas A&M is one of the places that's doing it. And so there are options for people that are motivated and willing to travel if they don't live near a surgical facility offering this. One of the things that came up at the Endocrine Society meeting was cabergoline and its impact on Cushing's management. Cabergoline is a dopamine receptor antagonist that within the pituitary gland, some corticotrophs that, in pituitary dependent disease are the ones that overproduce endogenous ACTH, carry the receptor for this version of dopamine. And so in a portion of patients, by putting them on cabergoline, you may actually be able to suppress those corticotroph cells and reduce endogenous ACTH production. And interestingly, what's been shown in the literature is that most of this is coming out of South America, Brazil in particular, that in some of these patients that they have microadenomas or macroadenomas, that it actually shrinks the tumor in patients that are responsive to this disease, to this medication. So they still use trilostane in these patients, but then they add on cabergoline at a dose of about 23 micrograms per kilogram given 3 days a week, so Monday, Wednesday, Friday usually. And so again, if you have a definitive pituitary tumor or a macroadenoma that the client can't do radiation or surgery on, then cabergoline may be an option. And hopefully it's one of the 40% that may respond to the therapy and actually have a positive treatment outcome as a result of it. So keep that in your back pocket if needed. For adrenal-dependent disease, again, adrenalectomy would be curative if it is the source of the excess cortisol production. However, for clients that cannot afford adrenalectomy, then trilostane is typically what we would still use. If you are going to do adrenalectomy, we usually recommend treating still for at least 4 weeks before surgery as a way to not perfectly control the cortisol levels, but at least try to get them down so that we minimize some of the wound healing, postoperative infection risks that can be associated with this uncontrolled Cushing's. And so most surgeons feel a lot better about having some level of cortisol reduction before they go in there and start mucking around in the animal. But that is also a good thing to at least offer to the owner. And if they decline it, then note it in your record and move on with therapy. Trilostane is still an effective option. Excuse me, mitotane is still an effective option. It's just that it's being phased out for use in people. And so it's a lot harder to find now. And it's also become a lot more expensive. And so a lot of times if we're using it, we have to get it from compounding pharmacies. But it is still out there and able to be used. And it is still a good therapy if you have an animal that doesn't respond well to trilostane. A couple of safety tips about trilostane, because we get a lot of emergency referrals every year for clients who aren't handling trilostane appropriately. And so I think I almost treat it exactly like I tell clients to handle NSAID administration. If the animal goes off food or water, do not give trilostane because the risk of side effects goes up exponentially in animals that are dehydrated or off food or water. If they have any GI signs, vomiting, diarrhea, again, the risk of becoming dehydrated is very high, and these animals should not be continued on trilostane until these clinical signs resolve. And then any signs of hypocortisolism, attitude changes, being lethargic, weak, collapsing will be an indication to stop therapy. Kind of along those lines, I usually get in the habit of whenever I dispense trilostane or mitotane, I'm also usually dispensing dexamethasone tablets for the client to have on hand at home. I think remember, we don't want to use prednisone because prednisone will cross-react with the cortisol assay, and so it will impact your ability to confirm hypocortisolism in these patients. And so try to avoid pred and use dexamethasone tablets. So I usually give them an anti-inflammatory dose of dexamethasone. Usually I only dispense a few tablets and empower them that if you notice lethargy, weakness, collapse, acute GI signs, give a dose and don't just sit there and wait for things to get better. You should be giving that dose of Dex as you're running your dog to the car to bring him in to see me or to bring him into an emergency clinic. And so it should be a way to just bridge that gap so that the animal doesn't decompensate before they can get him evaluated at a clinic. And remember, because it doesn't cross-react with the assay, as long as we get them in soon enough, we should be able to still ACTH stimulate them to diagnose the hypocortisolism. So after we start trilostane, trilostane will take at least a month to reach its full effect when you first start it. And so we have a couple of rechecks. We're going to schedule one in 10 to 14 days after starting. This is only to ensure that we have not misdiagnosed the patient and we've suppressed their cortisol concentrations and made them iatrogenically Addisonian. We do not increase the dose at this first recheck visit because they could still have continued response to their cortisol concentration over the next 2 weeks. And so only goal here, look at the cortisol and make sure it's not too low. And so things we're going to be doing are evaluating clinical signs and also doing an ACTH stimulation test. For monitoring of trilostane therapy, it is okay to use a lower dose, a fifth of the dose of concentropin for monitoring purposes. And so a 1 microgram per kilogram dose can be used for monitoring. This is great because it saves a lot of cost again associated with treatment. Now, I didn't say this with a diagnosis, but especially if you're going to aliquot this out, it is always better to overdose a patient with concentropin than it is an underdose. And so if you calculate a dose and it's 58.9, give 59 or 60 and don't give 58. So always kind of give the dose that is rounded up in these patients because you can maximally stimulate their adrenal glands and reach a plateau where you're not going to cause overstimulation. But if you understimulate it, you may not get the inaccurate result. So always overdose, don't underdose. Additionally, at the 30-day recheck, if they're still uncontrolled or showing clinical signs and their cortisol is not where it needs to be, then we would change the dose. And then again, anytime you change the dose of trilostane, it's always going to be the cycle of 10 to 14 days later getting them in for a recheck. You don't have to wait a full 30 days after changes like you did the first recheck after kind of starting trilostane. There is some timing requirements with the ACTH stimulation test for trilostane monitoring. And so we usually recommend starting the test around 3 to 5 hours after the animal got dosed with trilostane in the morning. So that way the test can be completed within 4 to 6 hours, which most animals are going to peak their cortisol concentrations, are going to reach max trilostane effect somewhere between that 2 to 6 hour window post-dosing. And so we're going to try to make sure that we capture the ideal time to hopefully help direct our therapy. To me, the biggest thing about this is if the first time I'm going to do a stim, I start the stim 3 hours post-dosing, I need to make sure I start the stim 3 hours post-dosing every subsequent stim moving forward, because otherwise it's going to be comparing apples to oranges. And so whatever you do the first time, you need to try to stay as close to as possible the next time, because there can be some variability. If you do 1 hour, one at 3 hours, one at 4 hours, one at 5 hours, you may get different results that are hard to compare what the true treatment effect or response has been. So try to be consistent with your timing depending on the patient. So our treatment targets for trilostane are going to be, most importantly, everything in endocrinology right now is controlled clinical signs. We want the animal to be happy, have a good quality of life. We want the client to be happy and able to manage the patient at home. Biochemically, what we're looking for is ideally a stimulated cortisol concentration of around 5. Doesn't have to be perfect. So if an animal's clinical signs are controlled and the owner is happy as could be and the stimulated cortisol is 9, I'm not pushing my luck. That's good enough for me. I'm leaving that dose the same and sending that patient on the way. And so don't push your luck, because it's much better to have a mildly elevated stimulated cortisol concentration than it is to push your luck and make the animal Addisonian. The other thing that I think gets overlooked a lot, and one of the reasons why I still recommend ACTH stimulation testing, is that assessing for a positive delta cortisol is also important. And what a delta cortisol is basically the change between a stimulated cortisol and the baseline. And so if we look at a patient like this, whose stimulated cortisol concentration is lower than what their baseline cortisol concentration is, this is concerning because this is a test of adrenocortical reserve of cortisol. So basically, if you're sitting in your house right now and I release a lion into your room that you're sitting in, you're going to squeeze out as much cortisol as your adrenal glands can make so that you can get up and run out of the house and not get eaten by the lion. And so in these patients, they don't have that ability to squirt out cortisol. And so if I release that lion in the room with this guy's going to fall over from hypotension and get eaten by the lion. And so these guys oftentimes may look clinically normal and not have clinical signs. And the only way we know something is wrong is by finding this negative delta cortisol. So I kind of liken this to like them walking a tightrope of all it takes is a new baby to come into the house, or the in-laws to visit, or a plumber to come do work at the house. And that could be enough stress to induce that patient to then go into a crisis. And so we'll talk about this more in here in a second, but this is one of the reasons why I feel like it is still important to utilize the ACTH stimulation test. So a couple of monitoring examples. We have a dog started on trilostane and we're at 30 days. And so we've already done our 10 to 14 day recheck that showed they were not hypocortisolemic. So now we're at 30 days. Clinical signs are only about 20% improved, so not great. And our ACTH stimulated cortisol is 4.6, which is biochemically within the target that we're shooting for. So we still have clinical signs, but it does not appear to be cortisol driven. And so I would continue with the current dose and then work up the patient for other causes of PUPD or polyphagia or whatever other causes that they may be, or clinical signs they may be exhibiting. Then we have this patient who, again, 30 days is 95% controlled, however, has a baseline of 2.1 and a stimulated cortisol of 1. So this is going to be a patient that has the negative delta cortisol. And this is usually what I'm talking about of they look fine and they don't look like there's an issue, but they are walking a tightrope. And so I think you can monitor them closely. If you have not dispensed dexamethasone tablets to this patient, I sure as heck would make sure that I dispense it at this recheck visit so they have them on hand in case there's any issues. Interestingly, one of my residents did a project back in 2016 that polled both veterinarians and internal medicine specialists and kind of said, in these situations, what would you do? And the vast majority of every veterinarian that responded would either modulate the dose or temporarily discontinue the trilostane if they got this result. And so most people recognize that this is a concerning change, that we don't allow this patient to have adrenocortical reserve to respond to stressors if they occur in the environment. So just be aware this is one of the reasons why it's really nice to use the ACTH stimulation test, especially for dose determination purposes. And then finally, monitoring. We know that it can be expensive and confusing. We know that there's a lot of different protocols that are out there that may be controversial. And we glaringly have this issue of iatrogenic hypocortisolemia that we need to deal with. And so I think once we get through the initial dose determination phase and we find the dose of trilostane that's going to work for the patient, most of us now are not recommending kind of regular cortisol testing at every 3 months or every 6 months. Um, Most of the time, we're letting clinical signs direct our decision making. And if the animal's doing clinically well, it doesn't matter what their ACTH stimulation test is. I'm not going to probably change anything associated with their therapy. Interestingly, we met with a group of internists as part of the AHA Select Endocrinopathy Guidelines task force, and most internists still recommend some form of cortisol monitoring as part of like their once or twice a year kind of geriatric animal health exam. And we'll talk about some of the options, but most people feel better about not just completely giving up on cortisol monitoring because of the risk of iatrogenic hypocortisolemia. And so kind of in my mind, the two options that we have are, do we rely solely on an ACTH stimulation test, or could we rely on something like a pre-trilostane or pre-pill cortisol concentration, which we'll talk about. Iatrogenic hypocortisolemia is going to happen. And you could do everything right in this patient. You've diagnosed it, you've treated it, you've monitored it, and that patient could still develop hypocortisolemia. It happens in about 15% of dogs within 2 years and a quarter of dogs within 4 years of being on trilostane. When it happens, about a third of patients are completely asymptomatic and show no signs and incidental diagnosis on routine monitoring. If they do show signs, it's oftentimes going to be very vague clinical signs like lethargy or hyporexia that may not be obvious that the animal's having a cortisol-related issue. Interestingly, it does not appear to be associated with the trilostane dose. However, it does appear to be more associated with the presence of comorbidities or concurrent diseases. And so a lot of the patients that develop this iatrogenically on a consistent trilostane dose oftentimes have other diseases that may be at play that alter the body's response to the trilostane dose. And so if most veterinarians, like we talked about, are presented with subclinical hypocortisolemia or clinical hypocortisolemia, then they're going to do something. And so oftentimes we may recommend a temporary drug discontinuation or a drug holiday. Usually if I'm going to stop it, I stop it for 7 to 14 days to allow the animal to build back up some adrenocortical reserve. And then I'll restart the trilostane at a lower dose. If they're asymptomatic or not that severely impacted, some people would just dose reduce the trilostane and then recheck to make sure that that allows them to have some uh, increase in their adrenal reserve. If they do develop hypocortisolemia on trilostane, 75% will recover within 6 months. However, some animals become permanently Addisonian, and oftentimes that sometimes is preferred because it's easier to manage a Addisonian sometimes than it is a cushingoid animal. But just be aware that we definitely have had patients that have become Addisonian. We stopped the drug and they never went back on it. And that does happen sometimes up to 25% of cases. And so it's, again, not anything you did wrong. We don't know if it's a adrenocortical necrosis or what happened that causes them to revert back to not needing trilostane, but we do see it with some regularity. Manufacturer recommendations after getting control are to do ACTH stimulation test every 3 months for routine monitoring and then 10 to 14 days after any dose changes. And this is kind of the chart they usually put in the package insert, but kind of as in summary, they want to improve clinical signs and ideally a stimulated cortisol between 1.45 and 9. Most people, endocrinologist-wise, aren't doing this, but we'll talk about what we do. A lot of people hate ACTH stems. There's a lot of different reasons why that occurs. One of the biggest things we run into has been the expense of the docosahexaene being a limiting factor because we're oftentimes doing a lot of stems in these patients over time that can add up for clients. And so I think remember, if you're using it for monitoring purposes, you can use the fifth of the diagnostic dose, the 1 microgram per kilogram. And oftentimes what I recommend doing is splitting up your vial. So reconstitute the vial and then split it up into aliquots. And then that way you can kind of more tailor doses to patient sizes. And so what we usually do is we take the 1 ml vial, which is 250 micrograms, and we make 5 50 microgram aliquots that are 0.2 ml aliquots. So whenever we do this, you want to pull up the 0.2 mils into a tuberculin syringe and then pull up a little bit of air to allow room for expansion of that docosahexaene once it freezes. You can freeze them for up to 6 months, but once you get one out and thaw the aliquot, you either need to use it or throw it away. So you can't re-thaw it after it's been frozen. But there is evidence to support that these stay effective for up to 6 months frozen and are still effective after a single thaw episode. And so again, this is one of those situations where if I calculate a dose and my dose on a patient is 98 micrograms, that patient's getting 2 aliquots or 100 microgram of concentropin for their ACTH stimulation test. So always overdose, don't underdose. The other big thing that um, is a problem with ACTH stimulation tests is that the stimulated cortisol results oftentimes may inconsistently correlate with clinical signs that are being observed. And in particular, there's a lot of variability kind of in what the finite number given is for the serial stimulated cortisol concentration. So even though an animal may be controlled, you may get a stimulated cortisol of 4 and then 7 and then 6 and then 9. And so that drives some people crazy. But again, we should mostly be looking at clinical signs. And so to me, it doesn't matter as much about what the underlying cortisol result is. Now we're going to talk about pre-pill cortisol here in a second. And I want to say the reason why this was originally explored as an option is because in Europe, concentropin became very hard to find and they couldn't source it. And so they acutely lost the ability to do ACTH stimulation testing. And so a lot of our European colleagues were stuck trying to figure out how to monitor trilostane therapy in their cushingoid patients. And that's where a lot of these alternative monitoring protocols originally came from. And so kind of one of the first studies looking at pre-pill or pre-trilostane cortisol concentrations was looking at, again, a cortisol concentration attained at the time that trilostane was due. And so if they got it at 7 a.m. in the morning, then this was the cortisol pulled at 7 a.m. in the morning. Because it was in Europe, Europe most of the time is recommending once daily therapy. So a lot of the dogs in the study were on once daily trilostane, which may not fit with what we recommend doing in our patient population in the United States. And the focus of the study was trying to differentiate well versus poorly controlled cushingoid animals. And one of the flaws in my mind was that the kind of the gold standard they were comparing to was owner-reported clinical signs. And so if the owner thought the dog was doing great, then they were automatically classified as excellent control. Whereas if they were showing some signs reasonable, or if they were showing lots of signs and poorly controlled. And so they were basically comparing the cortisol concentrations to that in addition to ACTH stimulation testing. While they did report on hypocortisolemia detection, it was not a major emphasis of the study, but to me, it actually was probably the most important aspect of the study, and so we'll talk about that. As a result of the study, their recommended range was if you're going to use the pre-pill cortisol concentration, that ideally it should be somewhere between 1.45 and 5 as a result for us to feel comfortable with that patient's level of control. These are just some of the results, one highlighting how none of these tests appear to be great, especially looking at the sensitivity and specificity of the pre-pill or stimulated cortisol concentration. But the table at the bottom kind of looks at pre-pill versus the ACTH stim and kind of these ranges that they were using based on owner-reported clinical signs. And I think one thing I hope you can see is that there is a wide variety of cortisol concentration. So to me, an animal not showing clinical signs with a cortisol of 0.8 is probably not excellent control. That probably is over control and would need a dose adjustment in that patient. So again, not perfect, but it was a helpful study to get it stimulated thinking about other monitoring protocols. Looking at this table, there was no differences between pre-pill cortisol and stimulated cortisol. So what they did was they actually combined the reasonable and poor control group and compared that to the excellent control. And when they did that, the stimulated cortisol fell out of being significant, whereas the pre-pill cortisol actually performed better. And so that's why they kind of were then recommending the pre-pill cortisol as a monitoring tool for trilostane therapy. And so kind of what's my verdict on the pre-pill cortisol concentration? In my mind, it's best used in dogs that have controlled clinical signs. And so kind of if you have that well-controlled animal that you're seeing once or twice a year as part of their, older animal health exam, then sure, I think this is a great, cheap, easy, fast test to be able to do to kind of just dip your toe in the water about how well the dog's doing at home. There tends to be less result variability over time. And so like we talked about with your stimulated cortisol concentrations kind of being variable from time to time, these results tend to be more consistent, especially when the patient's on a consistent trilostane dose. And so if it's pre-pill cortisol of 2, chances are it's going to be around 2 as long as that trilostane dose remains the same over time. But it's not perfect. And so I think the things we need to keep in mind with this is you do risk missing patients that are asymptomatic hypocortisolemic patients. So again, they may be walking that tightrope And you may not know that based on just looking at a pre-pill cortisol concentration. And again, you may miss those negative delta cortisol dogs that are again walking that same tightrope. So what the heck should I do as far as monitoring goes? This is probably my favorite paper ever that I use all the time, that basically nothing we do matters and that basically endocrinologists are crazy because no variable assessed in this study fit with providing accurate information about what discriminated between patients on trilostane being well controlled or not. And so really, I think it is a experience and comfort level with one, really letting clinical signs be what drives us and letting biochemical testing be an ancillary supportive test to what we're looking at the patient. So we always want to look at the patient before just treating numbers. And so in my mind, if I have a patient with no clinical signs of Cushing's on trilostane, I'm fine doing pre-pill cortisols. And so these are what I would do if they come in for their once or twice a year health checks. The ideal result for me is that they're greater than 1.45 because that uh, most mostly excludes the risk of that patient being hypocortisolemic. So I don't care how high the result is. So if the patient comes in and their pre-pill is 9 and they're not showing clinical signs, I'm not going to dose adjust my trilostane. So really, I'm only using this to screen for hypocortisolemia. So as long as they're above 1.45 and clinically doing well, then I don't feel too queasy about them being intermittently hypocortisolemic. If their result is less than 1.45, I would say probably the ideal situation would be to perform an ACTH stimulation test to make sure that they are adequately controlled and have adrenocortical reserve. You could monitor that patient carefully because if you look at some of these papers, a lot of the animals that had low pre-pill cortisols eventually, when stimulated, had plenty of cortisol reserve that they weren't problematic. Additionally, it's very important about timing. And so if the animal is getting dosed with their trilostane at 7 a.m., you need to check them at 7 a.m. for their pre-pill cortisol. So if your appointment is not scheduled till 10, you're not going to actually get an accurate reflection of what that patient's doing. And so if you are going to be using pre-pill cortisols, you need to schedule your appointments at a time where it fits with being able to get a pre-pill cortisol, or that client is going to need to adjust their administration of trilostane for the 3 days before the appointment to try to get them to the 10 a.m. appointment time so that way you're able to get an accurate reflection of what their pre-pill cortisol concentration is. One of the reasons why I like having the Truforma is because if you have to send out these tests, then that's going to be you're sending the patient out the door, you're going to get this result, and you may have to get them back in to do something. And so what we usually do in practice at A&M is that if we're doing this as a screening tool, we'll run it on our Truforma and we'll get a result in 15 minutes. And if it's abnormal, I can either do a stim or I could wait an hour and recheck the cortisol concentration. And most of the time, it's going to be above that 1.45 cutoff. And so again, it allows you to have that ability to get more rapid result reporting and not necessarily have to have the patient in and out of the hospital. And it, again, is cheaper than potentially doing an ACTH stimulation test if we could just repeat the cortisol concentration. Anytime a patient has clinical signs of uncontrolled Cushing syndrome, the ACTH stimulation test is the most appropriate test for you to do. It provides you the most information about if changing the trilostane dose is appropriate and if it is safe. And so I would always recommend, if they're uncontrolled, do an ACTH stimulation test. And these are just general parameters up there based on patients who are showing clinical signs and kind of what in general we would do with those guys. But again, it is so much more informative to have this information than it is to use a pre-pill or a 3-hour cortisol concentration. So I would always push people to use an ACTH stimulation test for uncontrolled patients. So in summary, I think hopefully convince y'all to ensure your clients are practicing safe trilostane administration and to not give it if it's sick, and hopefully to encourage people to have dexamethasone tablets on hand at home in the event that they do experience this iatrogenic hypocortisolemia. That clinical signs by far should be directing everything that we're doing with monitoring of trilostane therapy in these patients. And that if they're well controlled, sure, pre-pill cortisols are cheap and easy as a way to kind of dip your toe in the water, but ACTH stim should still direct treatment decisions if you have an uncontrolled patient. And then don't forget to come back and reevaluate and address persistent comorbidities like hypertension or proteinuria, because Arthur, again, got treated for his Cushing syndrome, but then required telmisartan to reduce his UPC and his blood pressure. And so we could have predisposed him to kind of complications later in life as a result of ignoring those things and not coming back to assess or treat them. So I'm happy to answer any questions that y'all have come up with. And then my email's up here in case y'all have any questions you want to shoot me.